kick off today's opening panel, please welcome Professor Phil Dalton.
To begin with, I'll have a couple of opening remarks. But first of all, in terms of my introduction, as mentioned, I am currently a faculty member at the University of Southern California. And in that role, I teach the MHA students and the EMHA students. And I know some of them are actually out interviewing across the country now, so maybe you'll have an opportunity to meet some of them. But before that, before I became a wild faculty member at USC, I was actually a conservative consultant that started my own firm, sold it to VHA, and subsequently before that, I was with Kaiser Permanente and St. Joseph Health System. So that's my background. In terms of a little bit of opening statement, the one thing to mention that I think today, that we talk about lack of agreement in healthcare, lack of knowing what direction we're going, the one thing that I think Democrats and Republicans actually do agree on is that the cost of healthcare is unsustainable. So if we look at per capita healthcare expenditures over the last recent years, it's over $10,000 per year on a per capita basis. $3.5 trillion nationally, and 18% of the gross domestic product. It continues to grow, and it continues to grow beyond CPI. So while it continues to grow, 88% of the money that's spent on healthcare goes to medical services, which are credited with only 10% of what makes us healthy. Meanwhile, while health behaviors represent 50% of healthcare outcomes, we only spent 4% on actual changing behavior and health habits. So far, we've failed to bend the cost curve. Managed care has failed to accomplish that goal, and people still want the freedom of choice that gatekeeper models don't provide. So many of us are pretty excited about putting our hopes on something different, which is the future of the empowered consumer or patient. As such, we are seeing new population health models, and new models for accelerating patient engagement and transformation. So I'm looking forward to hearing from our illustrious speakers and panelists at this conference over the next 2 days about different models and technologies. So I'll turn it over now to the panelists to introduce themselves and say a few words about where they are organizationally in terms of this transformation.
Okay, I guess I'll start since I'm on the So I'm Kim Pyles. I'm with Ochsner Health System based in Louisiana, the largest health system in that region and growing. I've been with Ochsner for about 1.5 years. But prior to that, I was with the Studer Group as an account leader for the Studer Group and a patient experience coach and a national speaker. And then prior to that, for about 20 years almost, deep operational experience. And I got into the Studer Group because I found that in order to drive results, which are the end game, right, the results, it took behavior and it took leadership and development of leaders, and that is what attracted me to the Studer Group, which I find works in what we're trying to accomplish now, which is a customer, consumer, patient-centered redesign of our industry. So as far as Ochsner goes, where we are in the journey to digitization, it is one of our key strategic imperatives. Our 3 main imperatives are establishing connectedness, establishing the relationship, and of course the highest outcomes. So when we look at where we sit, I mean, we've got some things that I think that are pretty good where we are. We have an Innovation Ochsner Center, and we invest a lot in wearable technology in order to manage populations. We've had several chronic populations right now that are being managed by wearables. One of the most significant in our hypertension population, we've seen over, I think it's 180 days. When you start with no wearable intervention, people are typically blood pressure under control around 12% of the time. We've been able to achieve for those who are in that program 80% of the time. Within 180 days, their hypertension is under control through wearable technology. Innovation Ochsner has allowed us to, and Epic, honestly, and then the partnerships that we have with Apple and Google to go pretty far along the realms of digitization. The most exciting thing we're doing right now, I think, is artificial intelligence and the application of artificial intelligence and predictive analytics in order to stop things from happening and intervene and create a new pathway. And so we've established recently artificial intelligence deep learning for inpatients in our flagship hospital. And what we've been able to see, and this sounds easy, but it was a tremendous cultural effort to get the physicians and the resources mobilized for this. But we have found that what used to take 60 days to predict, we can predict within 4 hours and intervene before a patient codes. And we've been able to reduce rapid response and codes on the floors by 40% since, and that's only been within 4 months of utilizing this technology. So it's pretty exciting. But again, what I find where we are down the road with digitization is that it's sexy, it's fast, it's really cool, and it is culture will eat your lunch in digitization if you can't establish a cultural framework. So on the one hand, we're pretty far along. On the other hand, we've got to build a culture to support it.
So my name is Aaron Davis. I'm the Chief Experience Officer for UMC Health System in Lubbock, Texas. I've been at UMC for 11 years and kind of started as a transporter and moved my way up throughout the organization. If you're not familiar with Lubbock, Texas, we're associated with Texas Tech Health Science Center. So if you like football, that's the Red Raiders. So that's what we're known for, that and cotton and dirt. So those are the three things we really stand for. In Texas, if you're not familiar, it's really spread out. And so UMC is kind of a hub hospital in Lubbock, and we're surrounded by 50 smaller critical access hospitals and others even into eastern New Mexico. And so a lot of our innovations and technological investments happens to be around telehealth and how do we engage the rural hospitals to help sustain them, especially when healthcare costs are increasing and payer mix is decreasing. And so we're investing heavily in trying to improve accessibility, both at the ambulatory services, so how do patients wait from home, or how do we make it accessible for them to want to stay and get healthcare when they need it and want it, and then ultimately how do we keep them in their homes in the cities that they belong to without having to drive for hours to get to healthcare. And so we're currently working with a few small critical access hospitals providing ER coverage for them so that they can maintain the doors open with nurse pracs and mid-levels while providing clinical provider oversight via telehealth. And we're also doing a cutting-edge ambulance telehealth modem where patients can actually be seen in the ambulance by providers en route to the health system to where we can appropriately route them where they need to go. That's kind of some things we're doing on the outside for telehealth and as well as regional outreach. More internally, we're focusing more around the patient experience and how that improves the ultimate patient journey throughout the continuum of care. And so first is access. How do they get into our health systems? And so we're trying to employ first same-day scheduling appointments, as well as schedule your own appointments via applications, as well as when they get in the door, how are we engaging them and tying attribution to the patient care provider. And so a lot of the times, especially in patient experience, it's hard for us to know which clinician is the one driving the outcome, or at least for patient experience, and which one's holding us back. And so connecting our EHR to our patient experience results at the EHR level allows me to see internally who I can coach and focus on as well as who can I reward and recognize. The last thing we're kind of late to the game is definitely wearables. How do I manage population health and engage the community with technology that allows us to help engage them on a more personable level? Right now, it's just we have 1115 waiver in Texas, so there are certain dollars given by the government to allow us to do some of these more cutting-edge, innovative practices. And so mostly it's just technological advances that allow us to do home visits, but nothing more in terms of a wearable accessible device that helps us do care. So that's our UMC.
Hello, everyone. Good afternoon. My name is Aggie Barden. I'm the Vice President in the Office of Patient and Customer Experience at Northwell Health, which is in New York. I know I'm here on a panel with people from the South, so I'm the New York or East Coast representative. But it really is an honor and a privilege to be with all of you this afternoon. So Northwell Health is a large organization in New York, spanning across all of Long Island into New York City and upstate New York. We have now 23 hospitals. We have 650 medical practices, a school of medicine, a graduate school of nursing, a research institute, a center for learning and innovation. And we're growing exponentially, and our whole focus is really thinking about how we can create an experience for our patients, which we call our internal definition of every moment matters. How do we create a culture of care and an environment where patients can get the care that they need when they need it, the way they want it? So we've been doing a lot of work in terms of different types of technology. We have a center for innovation where we actually have, it's an area where individuals can come in with amazing ideas to actually pilot and try things. And it's set up almost like a hospital-like environment. So it's an innovation center really to pilot new ideas. In addition to that, we are now starting a digital patient experience team. And this is new for us. We've really spent a lot of time looking at the way things could be better. We knew that when we look at the market, some of our competitors really were ahead of us digitally. And so we really took our time because we thought we wanted to do it the right way, get the right team members on board, and really get the voice of the patient and the family early in so that we can really find out what they need to move forward. So with that said, this team has gotten together and they have used many, many focus groups, our patient-family partnership councils, to get the voice of patients and families, and of course all the clinician stakeholders. And we are ready to launch an app this summer, which will really be using the digital process, talking about the things that we've mentioned earlier, access to care, wait times, and the practice setting. And what we decided to do is we actually decided to use our ambulatory area as opposed to our inpatient setting. So it's going to be piloted in one of our medical practices and one of our ENT areas. And we're really excited that that's starting this summer. In terms of wearable devices, we also have several piloting areas across the organization. They are in our emergency room. And also we have a physician group who actually presented here last year who actually created a patient identification shield. And it's a wearable device with a microchip in it that gets placed on the skin, either here on the leg or here on the hand. I feel like a model. And it is really tied to the smartphone. So this is really going to be starting, we're piloting it in 3 different areas. The first quarter will be in neurosurgery, then it will be moving to cardiothoracic, and then the emergency room. So I shared a little bit about Northwell Health. I didn't share a little bit about me. I'm actually a nurse by background. I've been at Northwell a very long, long time, and I've worked there in a variety of roles. But I have a critical care background and also a behavioral health background, which is very interesting, the combination. And I actually found myself in patient experience. And to me, it's something that is the core of really any clinician. Why we go into this is really all about the patient experience. And so the things that I feel really important about as we talk about technology is remembering the empathetic communication that must go along with the delivery system of how we're going to create this. So it is about what the patient needs, but it's the empathetic, humanistic piece that we cannot forget as we begin to implement this technology. Thanks.
Good afternoon. I'm Deb Dahl. I'm the Vice President of Innovation for Banner Health. And for those of you not familiar with Banner, we have about 30 hospitals in 5 western states, and we represent a microcosm of healthcare in the U.S. So critical access hospitals, large academic, children's hospital, heart hospitals, behavioral health hospitals, bazillions of clinics, all the specialists you can think of. You've got home health, you've got hospice, blah, 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 blah. So we think of how we do things as that opportunity, not just to change how things are delivered for our patients, but the opportunity to change how things are delivered across the U.S. So we get this chance to think big, act small, fix fast, and scale quickly for that highly reliable organization model, and work with some spectacular partners from a technology perspective as well from a payer partner perspective. So in our Banner Health Network, speaking of microcosms, this would be what many of you might think of as your insurance arm. In our insurance arm, there are something along the lines of 20 different companies that are made up of joint ventures with probably any plan you can name we've got a partnership with. So in our Banner Aetna joint venture, it's now we're doing innovations in applications, things like baby scripts, so that the moms will take home their scales and their blood pressure cuff and their glucometer, and it'll all be digitally collected. And as those trends change, we have that opportunity for their OB to either skip a visit because everything's going well. That number of 9 visits, or whatever the random number is literally, the OB docs tell me, a random number. It doesn't mean that's any clinical reason that you need to come in this many times during your 9 months. We just made up a number, stuck with it, and call it good. So you have this opportunity to reduce the number of visits, which is great for the pregnant woman who's been taking time off from work to come in, because she knows that her clinical information is valuable and it is showing that I don't need to take off that time. It also provides those little adverse trends that you were talking about with the artificial intelligence. And it says, uh-oh, the blood pressure is creeping up a little bit, heart rate maybe is going down, mom's weight is not quite where it should be. None of those are really off, but that combination of those things says, I think probably we should check in on you. So somebody will call, talk to mom, see what's going on, and may for follow-up with a visit in those kinds of categories. We use those tests in the Act Small model. So you can kind of imagine with Banner and our partners in the insurance plan, if all of those plans were saying, oh, I'd like baby scripts for OB. Oh, I want mommy doodads for this thing. And I've got 42 different kinds of technologies in the field with our obstetricians. That would be crazy. So we say, here's the partner, we're gonna pick one, we're gonna try it out. If it works great, we'll scale it up and everybody can have it in whatever fashion. And that next step for us is the complication of, okay, well, who's gonna pay for this? Baby scripts has the potential to be spectacular. In the pilot, Aetna's paying for it. In the long term, we don't know how that's going to work. So that's one of the discussions I'm most interested in over our day and a half period is how will we move forward in this payment model for this opportunity to significantly decrease the cost of care while improving the quality of care, the clinical outcomes, the patient engagement, and satisfaction as we go forward. So I look forward to the discussions with you to see how do we do this? Because I don't know.
You know, to your point, we were having the same conversation around, and I feel like we're coming to the conclusion. In fact, we just finished 3 days of strategy sessions around, and saying that, you know, we're probably going to end up in a capitated world where we're going to do the right thing end to end. We're, you know, the joint ventures with insurers are going to help us do that, and then it frees our clinicians up to do the right thing and use people to their strengths and to their highest level while, you know, facing the shortages that we have and how we use people differently and not worrying so much about reimbursement.
Yeah, and I don't want to take us too far off track, but our work as a pioneer ACO, we were one of those that had spectacular financial and clinical results. And at the end of that term, many of those programs we'd put in place, we had to shut down because there was no way to continue that. And it's that canoes going different directions and we have a foot in each one. It's making me personally nuts. So, nuttier, maybe.
Trying to tie in a couple of those comments with a question that maybe can be a little bit of a free-for-all here in terms of somebody answering and somebody supplementing. But one is with regard to, 30% of hospitals are losing money. And only 10% of the world is capitated. Kaiser has made that world work well for them, and they have the latitude to do a lot of interesting things in terms of these types of developments. You guys have all made great progress, but how do you get that culture given that there aren't evident payers? I mean, what are some of the secrets to developing the culture for getting a commitment under the challenging times financially?
Yeah, that's difficult in a fee-for-service world, right? I mean, I think that everybody buys into patients first and consumers first, but when you have fee-for-service world, we're at odds with what we're asking people to do. I think part of the cultural piece of that is we need to, as much as we're looking for ease of access, ease to the consumer, ease of connectedness, we need to also think in parallel with ease of practice for our providers. I think that one of the biggest angst that I hear directly from our physicians are, patients want to speak directly to their physician, email through the portal directly to the physician, that real-time connectivity with their provider. And the providers on the other side saying, I'm working 24/7 now, particularly primary care. So on the technology side of things, easing their burden of practice and making sure that those people who support them are savvy and supportive and trained and taking the time to do that in the fast-paced acquire, because part of the ability to capitate, you have to scale. You have to have the volume, which is why Kaiser has that luxury. You have to have the volume in order to do that. So growth and then maintaining culture and making sure everybody's on board, that takes time while you're trying to move fast.
Yeah. And again, we think that right now we're at about 10% of our patients are part of our plan, if you will. So we're not anywhere near the Kaiser model. And we think that 30% will be our break-even point. So in the meantime, we focus on the people process technologies that will have an impact for the patients in the current payer model. So, tele-ICU, which I know many of you guys probably have out there, has a great payback because it'll get your length of stay in an area that you can manage. It'll standardize your care. It has the opportunity to reduce the treatment times so that you get to see an intensivist at night. Tools like Mytonomy, who we've been chatting with earlier, which does the patient engagement and micro-learning for your pre-op and for your patient stay and your post-op. If you can reduce your number of patients that are coming back in or the number of times they have to call the office to find out, now what is it I'm supposed to be doing and how many times should I visit? You've got a financial ROI. But there are so many other opportunities out there that we just don't have a way as our box to make that payer work. And most of our partners are not out there willing to fund it. And it's great to have a partner that will, I'm going to say, experiment with you in the act small, but they're not there when you need to scale quickly. So we're still trying to figure that out.
Well, and look where the disruptors are entering, right? They're not entering hospital care. They're cherry picking the care and leaving us with the hospital care. So we have to think about that in our strategies.
So we have a similar issue. We had a lot of funding coming from CMS to trial certain programs, and the minute that the trial or the terms ran out, then we closed all the programs. So we had anywhere from 15 to 20 programs that were really good evidence-based, population health-centered, patient-centered programs that did some really great things focused around reducing overutilization of the emergency centers, or really providing a 24/7 nurse-funded hotline to answer any questions regarding care that would prevent them from having to need, extended, emergency center visits or a lot of different outcome-driven questions. And the minute the funding went away, they went away. And so we kind of experienced that both. And not only is it harmful for the patients, but it's also harmful for the culture of the organization because you have a lot of invested staff members and people that believe in the programs. And the minute the funding goes away, so do their jobs, or so do their livelihoods. So there's a kind of a double-edged sword. All good things for good purposes, but ultimately you have to have it funded. And so we trial certain new technologies in funded areas. And so we know oncology, cardiology, those are areas that we know have good payer mixes and that bring in revenue. And so trialing new technologies for the betterment of those populations because we know we can sustain it is somewhere that we've tried to really invest heavily in to keep those patients engaged and loyal when they need those services again to choose us versus choosing a different organization in the same demographic area.
Aggie, any comments on that?
You know, I think you mentioned something about services that really are better in terms of the payer mix, but I want to bring up something. We have a large behavioral health issue in our area, and that was one area that a lot of doors were closed. And in our organization, we decided that we could not do that, that we had to continue to really grow that area despite its difficulty with the financial return. So we really are investing in our psychiatric or behavioral health areas. And we also have now put in telehealth in those areas as well, which is also really, really important. But the one thing I want to raise also is about clinician burnout, because we're talking all about change in different pieces. And our last group had a great conversation about maybe we need to change the way we're delivering care. Maybe we have to look at new models to do this. Maybe it's not all the RVUs and everything else. Like maybe we have to look at new ways. And I think we have to really be clear that we're asking a lot of clinicians and our physicians, and we know that the burnout is happening, and we have to really look at ways to create resiliency, and then for practitioners to bring that compassionate piece back to the work that they love.
You know, given that your organizations aren't Kaiser, that have that PM to work with and use in whatever fashion they want, how does your organization, and maybe you might or you might not have a benchmark for investment, but you know, is the initiative coming from the board? Is it coming from the CEO? Does it come from the ground up? You know, what is the culture that goes on, and what level of financial commitment do you have for going in these directions?
Do you want to go first, Aggie?
Okay. Well, the first word that came to me, and maybe I'm looking at that bridge up on the wall, is Brooklyn. For those of you, Brooklyn is one of the boroughs in New York, and it's one of the areas that's very underserved. So just to answer your question, our CEO, Michael Dowling, is really amazingly invested in creating an environment that's best for all people. So we actually have gone into Brooklyn and have done a lot of work with those hospitals in that area, really to create a better environment from a supportive piece, because it really is important to look at all areas. And I think that, you know, we're just looking at different ways to really kind of make healthcare better across the board that way. So I think our board is involved, but it's also the vision of our healthcare leaders, primarily our CEO, who really believes in sometimes not taking the easy road, the most financial, viable road, but the areas that we really have to handle to serve our communities best.
And any financial, you know, so I know, like as an example, St. Joseph Health System in Southern California has created an investment fund, you know, where they actually put a certain amount of capital aside for these kinds of things. Any experience with that?
So we leverage philanthropy. Our philanthropy is tremendous for that. To allow, tremendous amount of money raised, more than I've ever seen at Ochsner. And I think Ochsner, to your point, is learning from this, that fast growth and that fast pace, and now stepping back to think about the relationship, the impact of psychiatric or lack of behavioral health care. We recently opened two behavioral health hospitals to try to meet that need, because honestly, it was doing the right thing is a win-win, because those patients were sitting in our EDs with one-to-one, and then being released back out only to come back again. So telehealth has its place with that for certain in the community hospitals in order to provide the psychiatric and behavioral health care in the EDs. But I would say yes, we set aside, of course, in your work toward the community, your benefit, you set aside dollars for that, but by and large, through Innovation Ochsner and research dollars, so a lot of this is under research, particularly for the population health and the wearables and the outcomes, and we're showing real outcomes. And once you start establishing outcomes, that is benefit to your bottom line through reduced readmissions. A healthier population is good for not only the community, it's good for our system. Organizationally, that awakening to mission is starting to come back, I would say, to understanding that all of these things are interrelated. And I think that's where we can get to the conversation of bundling the care and capitating instead of fee-for-service in order to really think about outcomes and experience and caring for our community and taking everything else off the brain. And it still will be profitable because you will have established loyalty, but again, you have to scale.
Were you thinking of it in the venture capital investment format?
Maybe. I
Maybe,
was kind of
okay.
thinking of, capital's hard to come by these days, and sometimes it's through partnerships. But if you just had any, example or idea or commentary on, we spend $5 million, we spend $100 million, however you find the money to be able to invest in these things that aren't necessarily reimbursable.
Yeah.
Right.
So at the moment, Banner does not participate in a venture capital kind of funding method, and our partnership with the University of Arizona down the street, because we're the owners of the academic hospitals, we rely on them and their investment in that space. But from an investment in process improvement, technology, ways to focus on the consumer, we have made a huge investment in that. So our entire mission statement for Banner Health has moved from we exist to make a difference in people's lives through excellent patient care to a focus on making, this is such a new one, I have to look at it again, making healthcare easier so life can be better. Now, that's a whoa turn for those of us who are here thinking we're all here for clinical quality. That's our life. And so now we're saying we have a persona of Sophia that we all think about all day, every day. And for those of you who are in the discussion, sorry for the repetition for a couple of you. What that means for us is anytime you're looking to make a change or any investment you make, you have to say out loud, what about Sophia? What does this mean for Sophia? And that's the name that we're using. So Sophia is sort of a woman in her mid-30s. She's married. She's got a couple of young kids. She's got her parents nearby, her in-laws nearby. Everybody's got healthcare issues, just like in a regular family, as you might imagine. And you have to stop and think, what does this mean? So for Banner, we've invested in a project called Imaginariums. And our Imaginariums, there are 5 of them. There is one that's the Medicare Advantage Imaginarium, so it's everything you can think of relative to Medicare Advantage, and they're located in a 10-mile geographic area from the Sun Cities in the Phoenix metro area. Gee, can't imagine why we'd pick the Sun Cities as a Medicare Advantage neighborhood. There is an affordability Imaginarium that's looking at what you might think of as the Medicaid or the no-pay population, and again, 10-mile radius around another particular hospital. There's the consumer-focused Imaginarium, again, another 10-mile radius in an area where it's highly employed, thinking about the millennials and that environment going forward. There's the digital garage Imaginarium that supports all of those others. What do you need from a digital perspective? And there's a leadership accelerator. So how do we change our leadership structure to match and make those changes going forward? And the resources into that are pretty extensive as we're moving forward. So lots of fun things going on and a little scary. Yeah.
That statement, making healthcare easier, is interesting to me because that's pretty much what CVS is saying. We're going to revolutionize healthcare. We're gonna make it easier, and who they're saying they're going to make it easier than is us.
So to kind of go back to the original question, where does it come from? What drives us? So for the board, our board is involved definitely in the decisions that are made for the organization, but it does kind of come from the ground up a little bit from our consumers, as well as just kind of staying with the times. And there's a book says, "What got you here won't get you there," right? And so kind of keep that motto going for technological advances. And so we have a budget, yes, associated with innovation and technological investments, but it is dealt with on a case-by-case basis. So we've built a 3 to 5 year strategy in terms of where we want to be when we're looking at the continuum of the patient care and consumerism as a whole, from access all the way to post-care follow-up. And so as we just really journey along that lines, I think it's expected in terms of the investment, as well as we just find vendors and partners that we know we plan to partner with, and we ultimately make the investment at that time. So it's a growing investment as we get along the journey, but we know at the end of the day it's for the ultimate good. And so it's money out the door that ultimately brings loyalty, trust, and ongoing income.
You guys have talked a lot about inpatient applications, and one of the groups out there that's really mad are employers. And they're seeing the cost shift continue to hit them, and they're really, discouraged and disappointed by it. And they're one of the fertile grounds for experimenting with these kind of technologies. Have you seen, are you working with any self-insured employers or other types of employer groups in terms of?
Yeah, we're aggressively going direct to consumers, direct to employers.
And what are you doing with them? What kinds of things are you
So
offering them?
around executive health type programs where they have the red carpet kind of treatment. Wearables are huge. We're approaching it as a population health model through our primary care and our executive health arm. So I think this is going to be a pretty successful strategy for us. We've done it now with a couple of large employers in the region. Shell is in our region, and they are one that we're beginning to do that with. And I think that is going to kind of be a playground for even broader population health management that we've already been diving into.
Several of our health plans in the Banner Health Network are really based on employers in the region, so they're the commercial plans direct to that employer. And part of our consumer Imaginarium is focusing on that particular population. And this is going to be really harsh, but what I have found in the discussions is they want to talk about all the cool, fun things that should happen and how you can reduce your employee absenteeism, but they don't want to do anything any differently. So, the costs are not in the cool app for the patient or in the wellness space. The costs are still in the, gosh, I had to go to the hospital for back surgery. And in real life, did surgery make a huge difference? Probably not. And I really appreciate that Boeing in the Seattle area is focusing on that, and Cleveland Clinic and some of the other folks are saying, send them to us and we will make sure they get the right treatment, not just that they wanted back surgery and you have an orthopedic surgery that loves to do back surgery, but that let's evaluate, and maybe back surgery isn't the right thing, and what are you going to do? And those are very hard discussions that most employers are not ready. They're getting there, they're just not quite there yet, and we're not quite there yet. I mean, we're not ready to say, hey, back surgery's stupid. Okay, we still make a nickel. we like to be employed.
The whole, connecting with patients, not just digitally, but really connecting, and then using data to learn about them in order to tailor the care individually. That's where that value comes in, of what do you really need as a patient, and then the shared decision-making that we've kind of all been talking about.
I think that shared decision-making is crucial. You get to the cancer treatment, and when does it move to feudal care? And that's an expensive model that is very hard to have that discussion with the patient, the family, and then you get the kickback from the employer, what are you doing denying care? Well, if you don't have a really good shared decision-making model, you've just destroyed a whole lot of trust that you've spent a lot of time building.
Any particular tools or techniques that have been especially effective in terms of developing patient knowledge and engagement?
I think one of the things that we did, especially for this new project where we're starting in our ambulatory area, is a lot of focus groups with stakeholders to find out what patients want, what they need. Is it the access? Is it scheduling? What is it that's important to them? So focus groups with patients, families, clinicians, the people actually doing the work to get that feedback. And then at Northwell, we have a large patient partnership council structure where we have individual partnership councils at each hospital site, and then we also have a system-wide partnership council. So we kind of get this information that goes up and down, back and forward, fluid, so we can get patients and families to actually get their voice and to vote on and give their input on what is important to them. So I think we can never ask, you have to ask constantly, what is it that we need for you? And as we begin to do this, the big thing that came up was the personalization of how they want that data to be personalized to them. So that if they're readmitted, it comes right back that, yes, you were here and you know something about them personally, so there's a connection.
Yeah, and that's kind of when you talk about tools. So, I mean, of course, we're an Epic shop. Epic and Ochsner partner constantly to try to figure out how to drive connection through the My Ochsner Epic portal and make it feel like they're home. And then, like Deb was talking about, we did the activity for about a year of developing personas using our marketing data and focus groups, and developed 4 personas that kind of sound very similar to what you're talking about around the younger not marrieds, the young marrieds without children, the marrieds with school-age kids, and then, you know, the next 2 phases and then what are those? I think the danger there is to, of course, start to stereotype people. You know, because that you get the stereotype that millennials aren't loyal, but I can tell you as a mom of millennials, they want to have, when they're sick, they want to have a conversation and feel like they were cared for by a person. So I think that tools are awesome, and we need them because we do have a shortage in physicians that's going to grow. We have a shortage in nurses that's going to grow, and we need ways to do this digitally through telehealth or through wearables or all kinds of cool things that we need to come up with. But at the end of the day, when we can't lose the human factor of what we're doing, we'll lose the game if we do that.
I think transparency of information for the consumer. So we always want to make sure that our websites, all the things, physician ratings, comments, all those anecdotal information pieces are at their fingertips so they can make an educated choice about where they choose healthcare. And so we want to make sure that that's up there, which ultimately drives search optimization when they're looking for a healthcare provider. So that's one of our tools and tricks. But we also have a very robust patient and family advisory council that we typically really rely on. We have a digital one as well as a real interactive one that comes in routinely. And so we poll our patients and our families routinely with new innovations, new questions, new things we're trying to do and accomplish. And one of the more recent, it's very small, but it's something that they really wanted that we did, was about access. So in our hospital, it's a very big hospital, large parking lot. In Texas, we don't really build up, we build out, you know, and so we have a large parking lot, and so they wanted a pinpoint app-developed access point for our shuttle service to pick them up where they're at. So they park and they can tell our shuttle service, I'm right here, and they'll come almost curbside service to pick them up to take them to the hospital. So that's kind of innovative. It's different. I haven't really seen that anywhere. Usually you see routes or buses that they have to wait for. And so it's kind of innovative, and it's very patient and family-centered.
You know, for each of you, kind of looking out to the future, if there's something that really gets you excited from a tool or a technology or an app standpoint, anything, you know, maybe for each of you to answer that, what's something out there that really gets you excited about what might impact the future?
Yeah, I think for me, it's the deep learning, artificial intelligence. You know, if you look at our physician, by 2023, we're going to have a 20% need that is not going to be met, and that need can be met through artificial intelligence. If you take, just for instance, radiologists, right? And, you know, radiologists perform a valuable service, but there's a certain component of what they do that artificial intelligence has been building and helping and could continue to help. And if it's applied, like for cardiac CT, you know, it takes a radiologist maybe 30 minutes to maybe an hour sometimes to go through all those slices and figure out the diagnosis that machine learning can do in seconds, right? 15 seconds. And so the FDA has finally approved, I think, Arteris to machine learning for radiologists for just this thing. For diabetic retinopathy, being able to slice through everything to see that something is going to be happening before it does, what the implications are for intervening, even in the home, you know, as hospital care, what we consider now acute care, transitions more to the home. Wearables will allow us, and machine learning will allow us to intervene and let somebody know that something's going to happen and you need to go here for care, and so that we can create a whole new pathway where we would have had the road down an inpatient stay and whatever could come from that to intervening and creating healthier populations that way. So I think that artificial intelligence, for me, is pretty exciting.
So I'm going to second that. I like artificial intelligence. To me, it's two things. It's really impressive and really creepy at the same time. And so it scares me to death, but it's really cool. And so I love the idea of the interconnectivity of things, right? And so a lot of the times technology is the one thing that we'll all adopt easily. and that we want to use. And so a lot of the times when we're trying to think through sustainability and financial, viability and how we can sustain it, when I can have any type of adoption rate from consumers because it's wearable or it's at their fingertips, that's a win. And so artificial intelligence, I think, is attractive enough to get consumers to want it and to keep it and to keep using it. So I think as that comes to the forefront, anything that's app-based or phone-based that the person can do and use and interact with the health system is ultimately going to help us be better, smarter, wiser, as well as more engaged. And so that's the one thing I'm looking forward to. Creeped out, but also encouraged by it.
I'd say the one thing I'm thinking about is what if we could create an environment where patients could come to have an appointment on the day that was best for them and not a time that works for all of us. If we could change that whole system of where healthcare was really truly accessible, and that also on this opposite side, that the clinicians also felt that same joy and purpose in their work, where they weren't overburdened by all the tasks they have to do with documentation and follow-through. So I guess to sum it up, access for a patient at a point in time what's best for them, and for the practitioner to have that joy back in the work they did because we created tools that made their work much easier.
I'd like to just say ditto. And think about it as not the patient having to come when they want, but the omni-channel approach that the rest of the world has moved to. Sometimes I want to go and see a provider in person. Sometimes I just want to enter on my phone the answer to 4 questions. Sometimes I want to take a picture of the mole and I want it to just do the AI to diagnose it. I want to be able to look at my tablet and it says, ooh, you are at very high risk for diabetic retinopathy, because now we don't actually need an optometrist, ophthalmologist to read that. But because I'm at high risk and it's shown that I'm at high risk, I need to go in and it'll just automatically schedule an appointment that fits into my calendar. So I'm looking forward to how all the pieces fit together. The technology is there. We just have to figure out how to get it into the real world.
Yeah, I just learned about a digital thermometer. You guys heard of this? The digital thermometer it's great and it's all connected. There's an app to that, but now it's being used to predict flu epidemic. And before the CDC understands that there's an epidemic in an area, and letting parents know that, hey, 3 kids at your son's 3rd grade class have the flu, you might want to keep your kid home today.
Creepy.
Right.
I'm glad you mentioned the creepy flu thing. I had a chance to chat, and you may have read this where there's I think it was Google. I can't remember. We met with Google, Amazon, and somebody all on the same day, so they run together at this point. But they can predict pancreatic cancer based on your searches on the web. Now, they don't know what to do with this, because speaking of creepy, if somebody said, hey, you've just asked and looked for things over the last 3 weeks that suggest you probably have pancreatic cancer, I mean, they're really looking for our help to say, what do we do with this? How do we get this information out? And it's not because you have the signs and symptoms and you're searching for pancreatic cancer. It's because of other things that sort of are the symptoms to get you there. So it's an interesting world.
Maybe give the audience here a chance to ask questions. Is there a mic?
My question is, one of our struggles is we have a great structure for value-based value analysis when we bring in products and all of that, but I'm finding with digital and IT, we're getting people that are bringing things from conferences, and our IT and technology people are bringing in ideas and maybe bypassing me. Do you have a structure in how you wrap this all up and help prioritize decrease redundancy? Because we're buying things that they both do the same thing in our organization.
So I would say yes, we do now. We did not always, and we were in a similar boat to as you described. So now we have a system where we have 2 VPs of digital strategy and then digital experience, working together with a whole steering committee, pulling in all of the OCIO and other stakeholders across the board. So this is new for us, and we're finding that's very effective, because then you can streamline and look at different projects and initiatives that you want to go forward.
I'll just mention that having those kinds of structures in place is absolutely spectacular, but if you also have your purchasing has some processes and your legal has processing that are that last step of, hey, IT has to sign off on this, or has innovation taken a look at that, then all the ones that kind of creep in from the sources, because if you're, I know that Bay State is in multiple locations, and you, like the rest of us, have some turnover, and folks will just sneak things in unexpectedly. So if there is a backdrop, it's really nice. It doesn't always work, but it's very helpful.
Yeah, I think that's key, because you'll turn around and be really surprised when you think you have a process in place and you still find stuff out there.
Yeah.
Other questions? Seeing no hands, I'll ask another one here. So talking about the Amazons of the world, which have some potential to take over this niche, what are you thinking with regard to your organizations and that potential? Is that something of a search for a partner, or a fear, or don't think it will go that way?
Oh, it's going that way. And like I said, they're cherry picking that. So they're not growing and buying hospitals. Nobody's buying hospitals but other hospitals and systems. But key to that, then we got to get better at and get that loyalty in the spaces where the disruptors are trying to get into, because they're going to get in. I mean, Uber is even in there. So it's happening. We have to make sure that we are understanding what's happening, and we build a strategy around that as well. But again, scale is key to that, and scale across all of those different types of omnichannel access points. When I worked for the Studer Group, if I traveled all over the country, and if I was sick, I just had a telemedicine visit, and it was awesome, and it was quick and easy, and I don't know why that's so hard to scale with healthcare systems.
I was just going to say, I think it's kind of wait and see what the card they play, kind of which area they're going to invest in and go into. So I think where they may have the funds and the energy around it, I think the good news is we have a little bit more expertise in that area, and so my hope is to be, to some degree, reactive in that space. So as they pick a niche, then we have experience, we have personnel that can hopefully rally and either compete and or just partner to make it better. We'll have a specific strategy.
I would just say the same thing, and that we have to continue to be innovative and find new ways to kind of, try something new that's around all this and then connect it.
I am excited about the opportunity that they bring forward, that there may be some things that they can do that we just can't do and haven't been able to pull off. I'm cautious that, Microsoft has tried this in the past, Google has tried this in the past, lots of other really big, very amazing folks have tried to pull this off, but there's that tipping point, and we may be there, and they may get a nice chunk of the little profitable segment that's left in healthcare, and if they peel that off, I worry about what that leaves for us as patients, not just as people who work in the industry.
Yeah, I mean, when you think about it, I had an opportunity to hear Ken Kaufman speak on this earlier this week, and his predictions are pretty dire. And we know inpatient admissions are going down. The old model of feed the engine, right? Feed the engine of the hospital. You want to buy clinics, you want to have physicians to feed that engine, fee for service. And now we need to quickly get our imaging out of the hospitals. Payers are not going to pay for hospital-based outpatient procedures, hospital-based outpatient imaging, hospital-based outpatient anything, and we have to get it out of our bricks and mortar. And just that reacting fast enough so that we're not left with, all of the undesirable, meaning not paying, because we cannot, no money is no mission. So what happens, right? So I think we need to in reacting to what's happening, we need to get proactive in understanding what's happening around us.
So we just conclude on time, and like to give a round of applause for our panel for sharing their information.